really appreciative of everyone who was able to join today, and know that the information that will be shared will be helpful and will be time well spent. Before we get started, I just want to thank Allie Orwig with the Indiana Rural Health Association for supporting Zoom. So if you're having issues, you can chat her or email her promptly, and she's very good to assist with addressing any issues. Everyone is on mute, but you're more than welcome to unmute your line or chat in questions. I will be monitoring chat, and we'll make sure that questions are addressed, but definitely feel free to unmute as well. Also want to thank Joyce Fillenworth and David Conrad with the State Office of Rural Health for all of their extra hours that they have spent in the COVID call center there at the state and supporting questions and helping facilitate answers. If you're coming up against questions and you're not exactly who to turn to, let Joyce, David, or myself know, and we'll work to get the answer for you or connect you with the person to best address your question. So today's webinar is on patient experience, best practices of high-performing critical access hospitals. We have with us today Karla Weng, who's presented for us in the past and just done an excellent job. Karla is a senior program manager at Stratis Health, and Stratis Health is kind of our go-to organization for MBQIP. Stratis Health has really been a rural health leader for as long as I can remember, and Karla has a lot of good experience in different rural initiatives and quality improvement as it relates to rural challenges. The presentation was sent out yesterday around 3:16 in the afternoon. The presentation is a great tool for your teams to use as almost a checklist to make sure that you've addressed a lot of these key HCAHPS, patient experience types of situations. So please make sure and access that and save it so that you can have that for reference if you don't follow along specifically with it today. I know it's a presentation that many hospitals have went back in the past and used to make sure that they've hit all of these key areas. So Karla, I will turn it over to you, and we'll begin.
All right, thanks Becky, and hello everyone. Thanks for spending some time with me today to talk about HCAHPS best practices and high-performing critical access hospitals. Becky already shared, I am from Stratis Health. We are based out of Minnesota. We're a nonprofit organization really focused on sort of quality improvement, collaboration in healthcare, and we like to say that we work at the intersection of research, policy, and practice. We're not researchers, we're not policymakers, and we're not in practice, but a lot of what we do is to try to connect the dots across all three of those areas, whether or not it's around technical assistance or education or other types of support and information. I am here wearing my hat of the Rural Quality Improvement Technical Assistance Center. We work with the Federal Office of Rural Health Policy, who is the same agency that funds the State Flex program. So David and Becky and the team, they get funding from that group as well. And so we are the one of our primary roles is to help provide additional technical and support around the MBQIP project for critical access hospitals. We're going to just talk a little bit about what HCAHPS is. I'm going to guess most of you are familiar with that, but I always like to do just a little bit of level setting there. We're briefly going to look at some of the current Indiana critical access hospital performance, and by current, I mean the data that I have available. So yes, it is a little bit old, but it's the most current data that I'm able to share with you in a rolled up manner. We'll talk a bit about best practices related to improving HCAHPS performance and kind of the different components and metrics. And then because we are in the time we are, I'm hoping we can spend a little time talking about some best practices related to patient and family engagement in our current environment, because certainly I'm going to guess in most of your hospitals, almost everything you do has changed in some way, shape, or form in the current environment. So how do we think about what is kind of standard best practice and how does that play into what's happening today and tomorrow and next week in your organizations? And please ask questions as we go, either through the chat or unmute. I'm more than happy. I'd actually love to have this be a conversation and not just me talking at you. So please feel free to chime in either through the chat or just take yourself off mute. It's a small enough group. I think we can manage that. So just a bit about high-level HCAHPS. MBQIP, again, is the Medicare Beneficiary Quality Improvement Program. It really focuses on support for critical access hospitals around reporting and quality improvement. So there is a common set of rural relevant measures that we focus on, and really ideally helps make the connection between quality measurement, quality improvement, and improved patient outcomes. So that's the overall goal of MBQIP. HCAHPS is a standard survey methodology for measuring patient perspectives on hospital care. So it really is an important driver of performance improvement related to patient perception of care. And at this point, the HCAHPS is really focused on inpatient, and we know that there's a lot of interest in kind of the emergency department or other settings. But the only nationally standardized reporting tool at this point is for the inpatient. There's also a CAHs, which would be for the clinic groups. So we are watching closely on progress around an emergency department version. And many of the vendors that you might work with do have an emergency department survey if you're using that, which kind of follows along the same lines, but it's not, we don't have access to that at a national level, which is one of the reasons we continue to kind of focus on the HCAHPS and the inpatient side of that. It does allow comparing performance with other hospitals based on national reporting. And one of my plugs is that it's pretty common for critical access hospitals to outperform larger facilities. Although I would say, because your larger facilities do have incentives attached to their performance on HCAHPS, that gap is starting to close. So I always encourage critical access hospitals to be attentive to where they're at on HCAHPS, because the natural advantage that you have in providing excellent patient experience is, that the bigger hospitals are starting to catch up because they're paying a lot more attention to it. So more broadly, I'm going to close the door so you don't hear my dog, sorry. Kind of the background of working at home. HCAHPS was developed by AHRQ. They've been publicly reporting HCAHPS data on hospital care compare since 2008, so it's been around for quite a while at this point. It has been required for larger hospitals since 2007. It's been an MBQIP core measure for critical access hospitals for several years. There's about 75 to 80% of critical access hospitals in the country right now do report HCAHPS regularly, so the large majority are capturing this information. And then there's a star rating related to HCAHPS that got rolled out in 2015. So of all the critical access hospitals that report HCAHPS data, about 40% actually have enough surveys to have a star rating calculated. So we see some volume kind of challenges there. You have to have more than 100 completed surveys in the most recent 4 quarters to have that HCAHPS star rating calculated. So it's about, of the hospitals that report it, of the critical access hospitals that report it, about 40 to 45% do get that star rating. Just broadly related to HCAHPS, so it really is kind of a focus on patient experience, but there is actually a growing body of evidence that shows that high correlation between hospitals that do well on HCAHPS and hospitals that do well on lots of other things. So health outcomes, adherence to treatments, preventative care, healthcare resource use, quality and safety. So although it really is trying to narrow in and look at what your patients say about their experience in your hospital, high scores are also correlated to lots of other positive performance results. And I think that's not surprising when we start to look at the best practices, which are really all around kind of teamwork and culture and leadership and how you kind of approach your work. So just a reminder of kind of how the data flows. The HCAHPS survey, I'm guessing most of you use a vendor. There are a handful of folks that self-administer, but that data ends up in QualityNet. And so that's how it fits with the other MBQIP measures. So again, the HCAHPS measures really are, this is the different metrics that lay out, but I like this little how was your experience today picture, because I think sometimes HCAHPS gets a little bit oversimplified. It's not just about whether or not people are smiling or frowning. If you actually kind of dig into the questions, there is opportunities to think about what's the cleanliness piece that might tie to some of your environmental services and your infection control. The discharge information and care transitions can tie into thinking about what you're doing in terms of readmissions and care transitions. So I think there's lots of opportunities to connect HCAHPS to other components. And my favorite story about this, how was your experience today? This was actually back in the day when we could travel. This was at an airport. It was outside one of the restaurants, and you could, push a little smiley or a frowny face. But then I also realized that it actually wasn't plugged in. So I'm not sure what kind of data they were capturing from that. Not very useful information. But I do feel like if you really dig into HCAHPS, hopefully you can find, I think the overall rating and the willingness is important to understand where you're at big picture, but there's lots of other opportunities to kind of dig into some of the components. So we're going to just talk briefly. I'm going to run through a few slides that show kind of generally where you're sitting in Indiana in terms of HCAHPS. I'm not going to go in detail on this this graph, because this is basically the rest of the slides I think I'm going to show you. This is the data that populated them. So the most recent data we had available to be able to kind of share back with you in an aggregate was from Q4 2018 to Q3 2019. So it is about a year old. And at that point, 27 of the 35 critical access hospitals in Indiana were reporting HCAHPS data. So we're going to talk about just a handful of the composite measures, what they look like, and the range. So the highest top box is usually what gets reported. That's kind of the highest scores, the most positive scores. The lowest box is where you don't want to be, and then we have a median, which is sort of in the middle. So again, I'm not going to talk through each of these because this is the data that populates the next graphs that I'm going to show you. So using the data from that box, I wanted to share you this. So when you roll up and you look at the overall HCAHPS, there's a couple of different metrics that seem to have the most power in terms of kind of coordination or correlation with overall high scores. Two of them are around communication. So communication with nurses and communication with physicians are two of the kind of individual measures that have a strong influence on how well your overall ratings look. So if we look at this in Indiana for the hospitals that were reporting, your range on communication from nurses is from 77% to 91%, and your median, so the middle bar in Indiana, is 85%. Nationally, the range is much wider, which is not surprising because you have many more hospitals, but nationally the range is actually 44% to 100%, but your median kind of sits at the same compared to other critical access hospitals. If you compare to all hospitals, the average is actually 81%. So again, on all of these critical access hospitals tend to do a bit higher. So I would encourage you to think about who might be at that 91% and what kind of things can you learn from them, and kind of think about where you might sit in that range. Communication with doctors, this looks similar. The range is much wider again here nationally, and a very similar range and median in Indiana. So as a kind of the median, the middle level for your folks in Indiana is at 84% for this one, whereas you have a range from 90 to 71%. And that national average is at 82%, so a bit lower when you look at all hospitals compared to just critical access hospitals. A third area that is highly correlated with overall high performance on HCAHPS is around responsiveness of hospital staff. And again, I think the range on this one nationally is pretty astounding. For 15% to 79%, your range is much tighter in Indiana, but broader than the other two scores that we had looked at, range from 63 to 90 with a median at 78. Still well above the national average when you include all hospitals, which is at 70%. Care transitions is one that we like to highlight because I think it has so much importance when you're thinking about care coordination and readmissions and how it connects to other aspects of care. Again, the range is typically wider on this one. The range is almost 100% here. It's 97% for the range for nationally, with the average of 57. In Indiana, your range is from 43% to 73%, with the medium sitting right at 56. So care transitions, this is the 3 questions to, that look at how well people understand what's next for them. This one almost always sits lower than the other HCAHPS scores, and is, I think, a continued opportunity to be thinking about how you're communicating and talking with folks as they're transitioning out of your hospital. So the overall hospital ratings, the last one I'm going to show you this range from. And from here, again, you see really wide range nationally. And in Indiana, you're seeing a range from 67% to 89%, with 76% right in the medium. Still higher than the national average for all hospitals is 73%. So I'm going to pause there and see if you guys have any questions about the data. Anything surprising to you?
Karla, this is Becky, and I know that a question that commonly comes up and we've been working on with critical access hospitals kind of ties into this overall rating of hospitals. And while other scores may be high, this does tend to be lower than what they had hoped. And wondered if you had any suggestions on marketing strategies so that the community really has a good understanding of the critical access hospitals. I know they've been focusing on services they provide as opposed to what critical access hospitals don't provide, but just wondered if you had any suggestions while we were on this particular slide.
Yeah, I mean, I think particularly if you're the hospital that's sitting at that 89%, that's where we're shouting out that, you know, we're looking at, the other one might be taking a look at the measure that, or the percentage of how many people give you like the highest average or would repeat customers. So I think there are opportunities to highlight your results here, either that you're kind of at or above the national average, or kind of where you sit in comparison. So that's definitely one opportunity, particularly if you're sort of sitting at that higher end of that range. And, you know, there's probably, you know, opportunities in some of, with the others, some of the more specific, but I think that probably the easiest to understand is sort of this overall rating of the hospital. Or if you have enough surveys to have that HCAHPS star rating, if you're sitting at a 4 or 5% star rating, I would also encourage people to be highlighting that when they're talking about their hospital and their community.
Thank you.
Yeah. The other piece that's not related to HCAHPS, but I will call out as well, is that one of the other areas we see people call out is the waiting times in their emergency rooms. So if you know, there's an outpatient measure that kind of looks at timing, or if you're kind of monitoring that, that's another place that I think a lot of times we see critical access hospitals highlight. Maybe not in our current environment, but more broadly, that's another kind of quality related metric that we see folks highlight. Any other questions before we dive into some of the best practices, observations? Okay. So I'm just going to walk you through a handful of best practices here. How we capture this information, it's actually from a couple years ago now, but I do think it's really, most of these strategies are really pretty evergreen. We did a handful of focus groups with critical access hospitals that either had the 5-star rating, so they fell into that 100 surveys or more. So I always have to put in air quotes when we talk about large critical access hospitals compared to small critical access hospitals, but there is a difference. So we looked at a handful of, we pulled a sample of hospitals who met that 5-star rating. And then we also did an approximation of a comparable rating for folks that didn't have enough to have that high star rating. So we actually did a specific focus group for lower volume critical access hospitals because we wanted to understand if the strategies were different, and they, for the most part, really weren't. We piloted, tested the focus group process with a handful of Minnesota critical access hospitals. You know, we live in Minnesota, they know us well, so they were a friendly test for us, and then we did a national sample. So the reason I call out Minnesota is because if you look closely at this list, there are lots of Minnesota hospitals on it. And although, you know, we like to brag that we're all above average here in Minnesota, and most of our Minnesota hospitals do pretty well on HCAHPS, there is a reason that we're oversampled here. So we do try to get good representation from across the country. And I'm just looking quickly, Perry County Memorial Hospital. Is anybody from Perry County on? You may or may not remember participating in focus groups a few years ago. But they were one of the ones that was highlighted. This is just kind of highlighting that, you know, the hospitals that we talked to for these focus groups, you know, their average scores were, you know, anywhere from 2% to 17% higher than a lot of the national averages. So the first thing that we asked them about, which I think is an ongoing challenge, is around response rates. So right now, HCAHPS surveys can be administered in 4 different ways. They call them modes. So you can either do mail followed by telephone, mail only, telephone only, or something called interactive voice response, or IVR. CMS and AHRQ are starting to do a study about expanding the modes to potentially have an electronic mode for survey response. So I know that's been a pretty heavy push for a while. People have been asking for that. I don't have any timeline on that. It's not something that's going to come up soon. This processes are on this move slowly, but they are at least talking about it. So that feels like it's starting to be kind of a crack in that wall, because people have been pushing for that for quite a while. So maybe within the next couple of years, there will be an opportunity for folks to be able to complete the survey online. At the time that we did this study, the national response rate was about 30%, 29%. The hospitals that we talked to, their average response rate was 38%, so a bit higher. Most of them did mail only. A handful of them did telephone. So you can see the comparisons there. Do any of you have strategies that you feel like works particularly well? This is what the groups told us, you know, making sure that people know they're going to get the survey. You can't, according to the rules for HCAHPS, you can't say, you know, like they do in a lot of the stores of, you know, please give us a 9 or 10. That's not okay to say that, but you can tell them that the survey is going to be coming, or that you'll be getting this in the mail, or you should expect a phone call. You can kind of remind people that that's coming. Another strategy is if you're doing leadership routing, a lot of times that maybe will be the leader that will say, hey, you know, we're going to be sending you this survey. We'd really appreciate hearing what you thought. And then also a strategy is making sure that if you're working with a vendor, that you're getting them your patient lists on a really regular basis. So the closer that the patient gets that survey to their actual stay, the more likely they are to fill it out. So any other strategies or suggestions that folks have found that has worked well in terms of response rates? We know that's kind of an ongoing challenge.
And Sandy Calvert from Perry is on, and so I've had a couple requests to maybe hear from Perry some of their best practices. So Sandy, if you're able to unmute, it would be nice if you could share maybe some of the things that you're doing.
Sure, Becky. We are doing very much a lot of the things that you have outlined here. We're doing hourly rounding, bedside shift reports, whiteboards, you know, just kind of giving people a heads up before they leave that they'll be getting a survey and how important what they have to say is to us. We use that for improvement. Yeah, nurse rounding. Let's see. We escort patients to and from places, like if they're going off the floor to radiology or, you know, wherever they're being escorted by nursing. We started 2 years ago with a Hospitalist program, and that's had a very good response. The physicians are there on the floor and readily available. I think those are just some of the highlights, some of the things that I can think off the top of my head that we implemented probably back in, I don't know, 2016 or so. And then I was just, when you brought that up about Perry, we got the award from MBQIP for excellence in HCAHPS scores in 2018.
Yeah.
So.
Nice. Well, as I walk through these, you just kind of highlighted my whole presentation. So please
Sorry.
chime in. No, that's perfect, because I want us to make sure we get some time to talk about some of the kind of more recent pieces. So as we're kind of walking through these, I'm going to go through fairly quickly, and then I encourage you to kind of chime in how you're implementing things, or if you have things to add, that would be awesome.
And Karla, we do have another question for Perry. Others would like to hear, are your scores consistent, and where do you struggle?
Our scores are not always consistent. We went through a period of time where in 2017 we had a little bit of a reduction in staffing. And so that resulted in just a little bit of turnover, and we noticed a dip then. It has since started to recover. I was just looking on hospital compared our HCAHPS. Of course, like you said, that is a lagging measure. But we did the best this last time I checked. I think it was November the 9th. Is the best that we had done since 2017. So we're starting to rebound. Of course, that was before COVID hit. But I think where we're struggling probably for consistency the most is in discharge and transitions.
And Sandy, I was also asked, how do you communicate to your community the types of patients that are appropriate for Perry County?
Well, we're a very small community, and so I venture to say most everyone knows everyone. But I think also we do an excellent job. Our word of mouth, our ED is, of course, the face of the hospital. And so there's always efforts to be moving, improve any type of improvement there. Social media is a lot. We have a new marketing director, and she's very much into the digital marketing, and that is constant, ever-changing, evolving. And we're very, very involved in other community programs throughout the hospital or throughout the community, community-wide, United Way, all of the chambers, just a lot of different things like that. Got a huge presence in the local newspaper.
Nice.
Perfect. Thank you.
You're welcome.
Excellent. All right, so I'm going to walk through these fairly quickly because you have a lot of the detail, and then we also have there's a whole report that has even more detail, and I want us to be able to get to the last piece. So just a highlight of how we pulled this out. What our key strategies are, things that we heard from several hospitals. Additional strategies are things that we heard from some hospitals. So that's not particularly scientific, but so key things are things we heard a lot from these the focus group. Additional are things that we heard some from the focus groups. So kind of really broadly, I think you heard a bit of this already, but the kind of key strategies across the board are really around kind of leadership engagement, whether or not they're rounding, whether or not they're kind of focusing on how you develop leaders across the whole scope of your organization, thinking about culture and standards of behavior, teamwork, accountability. And then data is also, I think, an important kind of overall strategy. So sharing the data with your staff and your providers often, having opportunities for discussion and suggestions, whether or not there's kind of opportunities for kind of friendly competition and momentum. One of the things I always encourage people to think about, if you haven't done it already, is that I would encourage you to have all your staff actually take the survey. Not that you're submitting it anywhere, but give them the survey and have them understand what the questions are. I think a lot of times, you might see this composite, but you might not really understand what actually goes into that. So I feel like that's a fairly easy way to sort of help people think about what's being measured, is just at a staff meeting or some opportunity, just kind of share here's the questions that people are answering that makes up, these scores that we're looking at. So that kind of fits with the staff engagement. We heard several hospitals have kind of it tied to evaluation or bonuses or pay per performance. a lot of conversation around the hiring process and hiring to fit and alignment with the culture. Particularly some of the larger critical access hospitals had some dedicated staff or committee kind of focusing on this. And then we also heard staffing ratios, which is a bit harder, I think, to kind of think about in addressing, particularly in our current environment. But that, I think we also even heard that from Perry County, that when you had sort of some dip in staffing, that seemed to have a bit of an impact. So nursing communications, again, this is one of the most highly correlated with a high overall rating. So whiteboards, as long as they're used faithfully and really used as a communication tool, just hanging whiteboards in the room isn't going to make the difference. You actually have to use them. Bedside shift report has also, and daily huddles have also been identified as really kind of key strategies in terms of helping folks kind of communicate and connect and make sure that they're talking with patients and their families. Again, the data feedback in the discussion, hourly rounding came up in a couple different places, but it did come up in the nursing strategy as well. Having some nurse leader rounding, so not just your staff nurses, but the leadership rounding and having some conversations, and then really having nurses sort of own and engaged in the process or ideas on how you improve the processes in the communication strategies.
Karla?
Yep.
This is Becky, and something that I'll share here about whiteboards. In working with hospitals, as they dug into the use of whiteboards and improvements in those particular areas, what they found is that other departments were not really fully aware of how they could utilize the whiteboards, such as physical therapy, dietary, etc. So just wanted to throw that out, that definitely make sure that it's communicated well and worked into your processes, that not just nursing, but other departments can utilize those whiteboards, and overall that improves communication for the patients and their families.
Yeah, excellent. Yeah, it is really, yeah, we kind of have it highlighted here under nursing, but it really can be kind of the interdisciplinary way to help communicate, as long as you're kind of consistent in how you structure and are using those. Yeah, the physician communication strategies identified were actually somewhat similar to the nursing, the data feedback piece. And several people felt like it was really helpful to have the nurses accompany the physicians on the rounds. There actually has been some empirical studies that show when physicians sit down when they talk to the patient, that makes a difference. Again, different environment than we're in currently, but having notepads and pens, having engaged physician leaders who are looking at this data. And then the hospitalist program piece, I think, again, is more because of the availability and that's kind of, if you're working with a hospitalist structure, they're much more available for that communication, and it's much more embedded in their role than if you have a different structure for your rounding physicians. Responsiveness of hospital staff, also really kind of a key when you look at the overall. The hourly rounding really came out here, although it was mentioned in several other areas, using kind of that 4 Ps when you're doing that rounding. So pain, potty, positioning, and possessions, checking in with people. That can also help decrease call light use, which is, I think, good for everyone. No pass zones is another strategy, which is essentially everybody answers call lights. So non-clinical support, if somebody needs a drink of water, anybody who's walking by can help get that drink of water. Or, kind of make sure that there's a connection. So making sure that there's responsiveness quickly rather than just waiting for the nurse if somebody else is in the area. A couple hospitals also said that by instituting sort of the no pass zone, they found that some of their staff who weren't involved in clinical care took the longer way around and decreased some of the traffic in their patient care areas because they didn't want to be in the no pass zone. So I don't know if you can imagine that in some of your own facilities, but I thought that was an interesting side note that then plays into some of the quietness and some of the other pieces that happen. 2 call light systems, some technology pieces that might be helpful, 2-way speakers and nurse communication devices were other aspects that people thought could be helpful. The escorting patients, this is where I know Perry, he highlighted this. If you think about this, I don't know what happens in your local grocery stores, but I have noticed at one of ours, a Hy-Vee, if you ask for something, they walk you there. Sometimes they don't know what you're asking for or where it is, especially when it's the teenagers helping you out. But for the most part, you know, rather than saying, oh, I think that's over in aisle 15, they take you there. This is really kind of a similar concept. So if somebody needs to go somewhere, then, you know, whoever it is that's on the floor will actually like make sure that they get there rather than just pointing the way. Scripting can be particularly useful in this area as well. Something as simple as, can I get you anything before I go? Is some pretty powerful as you're sort of stepping out of a room where your nurses are, helping kind of your CNAs or your patient care technicians use some of that language can also be helpful if you have those in place. And then patient-centeredness and customer service staff education sort of across the board of kind of, you know, the language we use matters and what does this look like across the board, not just with our nursing staff. Communications about yep.
Karla, if you don't mind me interrupting and going back to that, I did have a question chatted to me that does anyone else have semi-private rooms and 2 patients to a room? How do they overcome some of those barriers, particularly with rounding? And anyone can chime in if you've implemented some good strategies to kind of work around semi-private rooms and having that privacy.
Yeah, that's a great question.
Karla, how about you and talking with the high performers? Did they have strategies to maybe work around those patients that are in semi-private rooms?
Yeah, I don't recall that coming up as a particular conversation topic, but when I think about whether or not there's opportunities to try to have some of those conversations while the other patient is either in therapy or out of the room, I mean, that makes it can be complicated in terms of timing. Trying to help manage, yeah, it's a challenge, I think, in terms of the privacy piece and the conversation piece. And I would guess most of you right now, even if you usually have private rooms, are probably not in that, might not be in that situation. So I think that's everybody likes to have their own space, but sometimes that is not feasible. So being aware of it, I think, is also and, you know, doing the best with the situations you have, helping your staff think about, is there sort of some keywords that you can be using about privacy and discussion, and yeah, challenging one.
It is challenging. And if anyone has anything they would like to even share after the meeting, feel free to email me and I will share it with the group. That comes up from time to time, and that question, and we just haven't found anything real unique that's really worked well. So I'm interested in finding that out for all of our critical access hospitals that have semi-private rooms.
Yeah.
Becky, this is Teresa from Weng Memorial. Another thing I'd be interested in knowing is what other venues do you use other than the whiteboards for the communication? Or is there anything else that staff uses, or any of the hospitals? Just because that's another barrier for us with having double occupancy in a room. It's not, you cannot see the whiteboards from every angle, you know, from where they sit. We have beautiful rooms, great equipment. It's just how it's set up doesn't allow for that. So I would love to hear of any feedback, recommendations. Thank you, that's all.
I wonder if there wouldn't be an opportunity to have like a whiteboard that's not attached to a wall, that you could kind of help address that. You know,
like hook to the bed or something.
Yeah, or that, you know, you could pull up and then stash down, or not, but not having it as be as fixed. That might be a way to kind of have that easy. Or yeah, it's a good question.
Maybe I'll get with Hillrom and I'll invent it. And make it real well.
There you go.
All right.
Yeah. Good questions. Communication about medicines is the next area to touch on. For those of you that have pharmacy on site on a regular basis, pharmacist visits can be super helpful for this. We know that not everybody has access to that as a resource, but if there is sort of some key words and patient education materials that are in kind of really easy to use, training people around teach back, having those reminders and triggers in your electronic health record, those are other kind of key strategies to help support this as well. And I think you can not entirely relying on pharmacist visits, as with all of us, you know, hearing it multiple times makes a difference. So if we hear, you know, once or twice, this medication is for your heart, or, you know, when I provide a little education on the medicine we're giving you, you know, repetition is also valuable in terms of recognizing this. And again, you know, I always have to try to remind folks that HCAHPS is all about the perception of the patients. It's not about whether or not you did something, it's about whether or not the patient remembers it and had that perception. So I have a slide later to highlight that for you, but I think that's an important reminder when you're thinking about strategies and kind of processes. Cleanliness is, you know, I think always important, but certainly is really highlighted, I think, right now. So there's a couple things you can do around auditing that were identified as best practices, having notices of the cleaning services. So for example, if somebody cleans the room while the patient or family isn't there, tank call cards, that type of thing, like making sure folks know, have schedules where maybe they do the cleaning in the morning and then environmental services comes by in the afternoon to check in or kind of do a little bit. Those types of things can be helpful in terms of, again, it's about kind of that perception of the patient and their family, as well as how clean things are well. Thinking about trying to make sure everybody recognizes that they're responsible for cleanliness, you know, so kind of that team approach. Engaging your environmental services staff is really, they can be so valuable in terms of both customer service and just really kind of viewing them as a partner and support for that. We also saw some of this hospitals, if you have a patient and family advisory council, one of the things that they were using those councils for is sort of to do an environmental assessment. So just, you know, obviously not in our current environment, but at that time, walking through and like being in different areas of the facility. So if you think about your own house at home, you may have something that you don't even notice anymore. I'm always reminded of a time that we were fixing a screen door at our house and we hadn't gotten the trim back around the door, and it had been like that for like 6 months, and then somebody was over at our house and they're like, what happened to your door? And I was like, oh, we just haven't gotten the trim back up. I mean, we just didn't even see it anymore. So you guys are in your environment every day. I'm guessing there might be things you just don't see anymore. So that's where this kind of patient family advisory council might be pretty valuable in the event that we get to a point where folks can kind of be wandering around and saying, here's what I see when I sit in this space, when I'm not in that space every day, all day, if that makes sense. So opportunities to kind of get that perspective. Quietness is oftentimes a challenge as well. So awareness, I think, can be important. Noise monitors, I think, only get you so far. The squawk boxers that kind of go from green to yellow to red, at some point, I think they're good for awareness, but then people might hide them or be really irritated by them. So use those with caution. You know, written reminders. Some hospitals have done, you know, campaigns, those types of things. If you're in a position to be able to do structural changes, some of the ideas around kind of enclosed nursing stations or decentralized stations, those types of things can be opportunities. And then also just thinking, again, it's kind of back to thinking about what you probably don't see in your own environment. Are the doors squeaky? Are the carts squeaky? What are the cleaning and maintenance schedules? Those types of things that you might not recognize when you're so used to them. But is there different environmental noise pieces you might be hearing? Trying to have some quiet time, keeping the patient doors closed. Some places will provide like white noise opportunities, or having different music on care channels, earplugs, those types of things are also some of the strategies that folks identified. So this is usually where I highlight kind of the perception piece, because I think it can be a little confusing that there's a discharge information component to HCAHPS and then a care transitions component, because really you think that kind of seems like a little bit of the same thing. But really the questions about discharge are, did the hospital nurse talk to you, and did they give you information in writing? And then transitions of care questions are much more about whether or not I feel like my preferences were taken into account and whether or not I understood what was given to me. So I'm going to guess 99%, if not 100% of the patients that are in your hospitals get information in writing when they leave your door. I almost guarantee that. But yet only 89% on average of people who fill out the HCAHPS survey think that they got that information. So again, it's about perception, not necessarily about what happened. So I think that's a really important call out when you're thinking about this. And then the transitions is discharge information component is really like, did you do it and did they perceive that this happened? Transitions is much more about their own understanding of what's next for them. So that's why I feel like this transitions of care piece can be super valuable in terms of thinking about how you're supporting kind of the care transitions and addressing either readmissions or other opportunities to support your patients in follow-up. So discharge planning, solid processes around that. Having a social worker, if you have them engaged, some places have discharge planning nurses or case managers that kind of focus here, rounds or huddles, making sure you have the disciplinary involvement in that. Discharge education, consistent materials, whether or not it's a packet or a folder or a binder, sort of the simple language piece. If you haven't done anything around kind of teach back as an opportunity, there's some really good resources available around that with health literacy. And then whether or not you're doing kind of discharge phone calls or home visits afterwards. We did have a handful of critical access hospitals at that point that were doing home visits. They were less common, and those tended to be the smaller and more frontier hospitals that were doing those follow-up home visits at that point. We know that some folks are in accountable care organizations or other sort of value-based organization contracting that a lot of times that you maybe would be doing some of that follow-up in conjunction with the folks from the clinic and kind of lining that up as well.
Well, this is Becky. Were they able to bill for those home visits?
At that point, they were not. I think the environment is kind of shifting a little bit. Yeah.
Okay.
And a lot of times too, it's sort of that balance between whether or not you bill for it or whether or not, especially if you're in a value-based contract, it's just best practice of care that then helps reduce avoidable cost. So you kind of have that tension. Yep.
Thank you.
Yep. A couple other strategies, the whiteboard, again, whether or not you're able to have some dedicated staff that really focus on that transition and those discharge supports, and then EHR triggers to help ensure that folks are getting back in, and how you're able to connect to your providers in the clinic. That kind of ties into these transitions of care strategies, which these are kind of additional thinking about, ensuring that you're doing kind of simple language, understanding around patient responsibilities, sort of keywords around, one example would be, we want you to have a good understanding of your preferences, and then helping, again, helping people understand what the questions are. So these are the things you're being measured on. That can be an important component. So a couple resources to highlight, and then I want to dive into a couple COVID-related pieces. This study for HCAHPS best practices, that contains all the details about the stuff that I just shared with you. We also have a quality improvement toolkit that has best practices kind of by measure that's available. And then HCAHPS Online is sort of your standard source, kind of everything related to HCAHPS is on HCAHPS Online. So clearly we're in a little different environment right now. So just wanted to share a couple of things regarding what people have identified in terms of best practices related to particularly patient and family-centered care and communication during COVID, when your visitors are restricted and how you're going to be able to communicate has changed. So a couple of the best practices here that have been identified is making sure that you're thinking about patient and family-centered language when you're talking about this. So framing things as precautions rather than restrictions or lockdowns. It's just, I think language is important, and that is a powerful suggestion. Making sure that you're as clear as possible about specific changes and what they mean. So what is the timing? What are the, if you are having visitors, when can they be there? What are the screening procedures? Are there exceptions of when you are allowing visitors, comfort care, end of life types of things? So being really clear about what the guidance is. And then using a lot of communication channels to make sure people understand and know that. So right as people are admitted, making sure you're trying to communicate with those families, having it posted on your website, any sort of channel. I think worst case scenario is that somebody shows up and then says they didn't know anything about what was going on and isn't allowed to see their loved one. So I think it's a really challenging environment right now. So the more you can communicate and be clear about sort of what the requirements or what's in place, the better, and the more channels you can use that, the better. And then also maybe helping arm some of your support staff who are directly communicating that to be kind of clear and respectful about how they're communicating those changes in policies. So maybe having some standard scripting or statements that people can use when they're answering questions or getting asked questions about visitation in particular. Trying to maintain connections as best possible, whether or not that be using different technologies. Trying to maybe designate a care partner or essential caregiver role. You may not have that kind of spouse or daughter or son or family friend that's always the one that's visiting now. You won't know who that is a lot of times. So can you designate up front who is sort of that key person that you should be communicating with and connecting with? And then internally, making sure you have clear roles on who is responsible for facilitating that communication with family and caregivers. And then also documenting kind of what the communication preferences are and the contact information. So, I mean, it's obviously really kind of an emerging environment in many cases. So that's just a few kind of tips and best practices that I found in doing some digging around this. The Institute for Patient and Family-Centered Care has some really nice resources that I've highlighted here. In Minnesota, one of the things we've done here, our Alliance for Patient Safety put together some resources around kind of helping ensure what it's like to an in-person care partner looks like, what that role is, and how to connect that. There's some nice resources from Planetree and a couple other resources linked there as well. And then finally, I think just really important to be attentive, and I think you're all probably doing your best here with this, is how do we help, support our workforce in really stressful times. So even though not directly related to patient and family-centered care, I think pretty important that your staff feels supported and has those opportunities for mental breaks and mental health support. So also connected a resource in the Institute for Healthcare Improvement there for you guys as well. So what are you guys seeing, learning, any strategies or tips you would share with your colleagues for kind of the current environment?
And please feel free to unmute your line or chat in, and I'll be glad to read that for you. I know that one strategy is the Commit to Sit initiative that some of the critical access hospitals have instituted, and that there are then challenges in doing that when individuals are positive for COVID and needing to restrict maybe time in the room and equipment that is needed to put on once you go into the room. So Karla, any strategies as far as improving maybe a Commit to Sit type of program where staff members go in and just take a few minutes on their shift to sit down and talk with the patient about different things. I know that in that program, often some social determinants of health are identified that maybe would have been missed otherwise, because it's more of a conversation with the patient and not necessarily an intervention where you're going in specifically to do a task. But just wondered if you had any feedback around that, Karla.
Yeah, I mean, I think if you're able to continue to support that implementation, that is fantastic. That extra time is super important. I don't have other suggestions around making sure that happens, other than I think kind of what we've talked about is, if possible, to carve that out and not have it be something extra, but have it be part of somebody's day-to-day role and work. And again, I know we're in a challenging environment right now. So at some point, if you're having to look at, you know, what pieces and parts can we have give on, that's, I mean, I think has to be maybe part of the conversations. But if it's clear that that's part of somebody's role and you're able to carve out the time for them to continue to be able to do that, super important. Yeah.
Yeah. And just a few minutes a day can make a big difference. It doesn't have to be for a long period of time, and just giving staff that permission and acknowledgement is helpful.
Yeah.
And them feeling
Hey, Becky.
Uh-huh.
Hey, it's Elizabeth Burrows, and if somebody's on from Pulaski, they might want to share information. But they set up their chapel. We were talking about how to support staff. They converted their chapel, since it wasn't being used, into almost a mental health break location, with snacks, color sheets, stress balls. The social workers put a lot of resources in there, some deep breathing exercises and things like that. And I thought that was really a great practice.
Nice. Yeah. Having that kind of safe space, for lack of other term, where people can kind of just take a time out. Very important.
Yeah, and it was a way that it really helped the primary care staff embrace the behavioral health staff that were new. So that was an exciting partnership too.
Yeah. Yeah, thank you for sharing that.
Anyone on from Pulaski that would like to elaborate? You're welcome to unmute. Yeah, it doesn't sound like there is, but thank you for sharing that, Elizabeth. That's nice.
Yeah.
What other questions or comments do individuals have in our last few minutes here? I know these are definitely trying times, and if you are struggling with a particular issue, definitely reach out. We have a lot of good resources on a national level. Many of the resources that Karla has listed here in the presentation, they have several tools, videos, etc., that would be helpful, not only in patient experience, but also improving staff satisfaction, because staff satisfaction definitely plays a key role in patient and family satisfaction and their experience. So
yeah, I think that's just one last slide to share with you guys here too. I do think that really, when you think about bigger picture, a lot of what we talked about sort of lines up with lots of best practices across the board. So kind of that culture and the communication, the engagement, resiliency, it's all, the dots all connect together. So we know it's a super challenging time right now, and I just want to thank you for taking the time out of your day to be with us today, and thank you for all that you're doing to keep your staff and your communities and your families and your patients safe.
absolutely. Thank you all so much. And we will send out the link to the recording, so please feel free to forward that to others at the hospital that would find the information helpful, and we're always here to support you. So stay safe and have a wonderful Thanksgiving holiday weekend, at least as much as possible during these trying times. Thank you so much.
Yeah,
Bye-bye.
thank you.